Welcome to the Research Works podcast, brought to you in association with Curtin University and the Healthy Strides Foundation. Your hosts are Dr. Dana Poole and Dr. Ashley Thornton, and together we will interview world-leading researchers in the area of child health to support your practice in being more evidence-based.
The team at the Research Works podcast acknowledges the traditional custodians of the land and waters on which we live and work. We pay our respects to all First Nations peoples, elders past and present, and would like to acknowledge the traditional custodians of the land on which we record this podcast each week, the Whadjuk people of the Noongar Nation. We recognise their continued connection to this beautiful budja we call home.
Welcome to another episode of the Research Works podcast. Now, today we have the wonderful Marissa Smith back on the show, joining me to interview our very special guest today. So firstly, hello Marissa, and thank you for joining us again.
Well, it's always good to be back. Thanks for inviting me back. It must mean I'm doing something right.
Well, people do talk about how you have a nice radio voice. So, that's why you get invited back.
It's quite a compliment.
It is a compliment, isn't it? No, it's really cool. So I guess, what we also want to be able to do today is just to be able to use your expertise as we interview this very special guest today who has only just handed in her PhD. So we're very, very excited to speak to her. So welcome and congratulations, Anna to Velde.
Thank you so much. It's so lovely to be here and nice to be talking to you today, Dana and Marissa.
Yeah, fabulous. Thanks for being here.
Yeah, it's so great to meet Anna and like I said, reading your article that was just so recently published. But what I'll do is tell the people a little bit about you before we get started.
Yeah, that sounds good.
Sounds great.
So to tell you about Anna, like we mentioned, Anna recently completed her PhD at the University of Sydney. She's also a research physiotherapist with the Cerebral Palsy Alliance Research Institute in Australia. She has over 10 years' experience as a paediatric physiotherapist, working with children and infants with cerebral palsy in Australia and Bangladesh. Anna is an Australian Rotary Health Scholar with a research focus on early diagnosis and classification and effective interventions for infants and infants with cerebral palsy. Clinically, Anna works as a physiotherapist at the Cerebral Palsy Alliance Early Diagnosis Clinic, Australia's first multidisciplinary early diagnosis clinic for cerebral palsy. Anna is an investigator on the early natural history of cerebral palsy study and international collaboration tracking the development of infants with cerebral palsy and high risk of cerebral palsy over the first 2 years of life. Anna, this is impressive. Wow.
Yes, thank you. It's definitely exciting to be here. So, I've been a clinician for a very long time and just very recently breaking into research. So probably similar to lots of people listening.
I guess that also often happens, isn't it? You work clinically and I don't know about you, but I didn't think I'd get into research until you have those real nagging questions, don't you? And then you just get sucked into it. And then once you're in it.
Yeah, that's exactly right. Or parents are asking, what about this and what about that? And right, we need to go and find out. That's right.
Oh, well, congratulations on doing that, because it's not an easy thing. Like whilst you're working, and to stop the flow of that and to take time off to do it takes so much commitment, but our field is so much better for it. And we forgot to mention earlier what the paper we're going to be speaking about today, and you'll sort of see why we're so excited about it, because of the body of work that goes behind this. It doesn't, these things don't just happen overnight. It takes teams and hours of work. So the title of this paper is Neurodevelopmental Therapy in Cerebral Palsy, a meta-analysis, and it was literally just published in Pediatrics like last week. So it is very much hot off the press. So it's very, very cool. Now that we know a little bit about you from a very sort of professional perspective, as we always have an icebreaker question. So we want to get to know you a little bit more. Marissa, what question have you got for us today?
Okay, brace yourself, Anna. Today's question, I'm joking, is what sport would you like to compete in if you were in the Olympics? Can be winter or summer.
Look, this question really made me smile a lot, because I'm pretty much the least sporty and least competitive person going around. So the Olympics have actually just never been on my radar. But having said that, I really love getting out in nature and getting remote. And if I can, I just love to get my backpack on and go hiking for days on end. But I'm going to say last time I looked that hiking was definitely not an Olympics sport.
You never know.
I'm probably a fair way off going to the Olympics, that's for sure.
It's funny because I think when you go into physio, certainly when you first go into physio, it's always about, sports physio, and pediatrics wasn't something you really thought about. And I wasn't particularly sporty either. Like I could run, but my hand-eye coordination wasn't particularly good. I was always like an individual person, individual sport person, I think is probably the best way to describe it. So if I were to choose something, I have two. So for my winter sport, it would be like figure skating, because I love the idea of like, the speed and the jumps, and it just looks so elegant. Yeah. And if it were to be a summer sport, I would probably go for something like basketball, because I'm quite short and I love the idea that, I could be some pocket rocket and be really, really good at something like that. It's just such a fantasy though, and that's probably why it's my answer. It's so far off from the truth. Marissa, what about you?
Watch out, Dana, you've let that out. Now I'm going to try and recruit you. Probably basketball too. Look, it is my passion. But when I first saw that question, what came to my mind is pole vaulting, which I actually don't know why. I am not agile in the slightest and don't think I could fly over a pole. But it's just something about it. When I watch those athletes do it, I think it's actually just blows my mind. It's incredible.
It is, isn't it? There's a lot of courage involved with it. So that's probably why I like to watch it.
Me too. Let's watch it. I don't think,
not do it.
Well, good question. Thank you very much, Marissa. Well, let's get into it now, because I think there's a lot to go through and I'm sure everyone's really excited to hear about it. So let me give you a bit of an overview of this particular paper. So the objective of this meta-analysis was to determine the efficacy of neurodevelopmental therapy, or Bobath, for any outcome in children and infants with cerebral palsy and infants with high risk of cerebral palsy. The team conducted a meta-analysis on randomized controlled trials comparing NDT with any or no intervention, with standardized mean differences being calculated. Quality was then assessed using the Cochrane Risk of Bias tool, and certainty using the GRADE, or Grading of Recommendations Assessment, Development and Evaluation. Of the 667 records screened, 34 studies in 35 publications comprising of 1,332 participants met the inclusion criteria. After reviewing a number of conditions, the study found that activity-based and body structure and function interventions are more effective than control, and higher dose NDT is not more effective than lower dose. The research concludes that de-implementation of NDT in cerebral palsy is required.
Anna, you raised so many important points in this publication, but I think let's start with talking broadly and speaking about, if you can answer what NDT is.
Yeah, so NDT started in the 1950s. It's actually also called Bobath, and it was started in the 1950s by a couple. They were called Carol and Berta Bobath. And I think it's really important up front to recognise the massive contribution that the Bobaths have made to the field, because they were really the first ones to acknowledge this idea of rehabilitation potential and improving outcomes for children in CP. And that was a time when only compensatory strategies were used. So if you couldn't walk, you were given a wheelchair and see you later. So it's really important to, frame that up about when this therapy started. Often these days it's still described as usual care. There was a recent Delphi done that came out with the three main principles around what NDT comprises. Yep. And that idea is that there's movement analysis of task performance. Another principle is there's interdependence between posture and movement. Yep. There's also this principle that there's a role of sensory information and how that works in motor control. But what it means in practice, and the elements around that, is that therapists control or facilitate movement using handling of children. Yes. And what they're trying to do is train movement quality, or trying to normalise towards what they call typical movement behaviour and minimising atypical movement behaviour. So it's really training that movement quality rather than trying to use compensatory strategies or atypical movements.
Yeah, and the way you describe that is really familiar, like, in terms of a background. I think it's great that you acknowledged, the development of this back then. I remember learning about that as well. And if it wasn't for their contribution, we wouldn't have been thinking about, the potential for rehabilitation for these children. We went from a very institutionalized approach, way back then. And, we've evolved over time with that. And I was trained as an NDT therapist as well, about 2008. And, I think I have to admit, when I did the training, I felt like such a physiotherapist, because I was often the image image that I had in my head was a physiotherapist was there handling the child. You're holding a particular point of the body and you're seeing something else happen, and your hands are there and you're constantly assessing that quality, weren't you? That real position that you'd see. So Anna, can you just talk a little bit more about that sort of facilitation component of it and what that sort of, and the role that you sort of touched on there about the normalization of movement? Can you just explain that a bit more?
Yeah, that's right. So I guess we know in cerebral palsy, a part of the definition of cerebral palsy is there's a disorder of movement or posture. So children do come with these seemingly abnormal postures. And so this idea of facilitation, or the hands-on part that you were talking about, is the idea that sensory input is given to the child, and that then facilitates a more normal movement. And that the idea is to try and normalise these movements that children have, and that's the main aim around how these therapies work. And you're right, I think, and even sometimes parents can talk to us too about physio's hands go on, or we're teaching parents how to put your hands on, and the movement looks more normal, and that this was the main aim of what we were trying to do. But we're finding that that's actually not the most effective way to improve things that matter for children, which is really function and being able to get around.
Yeah. So a question on that then is how commonly, like, do you know how commonly NDT is used as a treatment sort of now and within current practice? Is it quite frequently?
Yeah, so it is still relatively common, which is part of why we did this work. So we looked briefly across the literature, and we found it's different in different countries. But, for example, we found between about 30 and 60% of therapists in the UK use NDT. There was a report from Norway, and between 7 and 54% of therapists said that they used NDT. And even here in Australia, there was reports between 8 and 33% of therapists using NDT as a part of their practice. Yeah, so it's quite common.
Wow, that's probably more common than I realised. And have there been any changes? I mean, obviously, since the Bobath had developed it in the 50s, has there been much documentation about how it's evolved over time?
Yes, so there definitely is written about how things have changed over time, because we're all constantly reevaluating our practice. So that's not surprising. That's a good thing. Probably the biggest thing across the literature, or what's well known, is that because it's so commonly used internationally, that they're finding different countries have almost different types of therapies that they are calling NDT or Bobath. Sure. So it can be quite an eclectic range of therapies. Yes. And there are definitely some reports, and you'll see in this paper too, it's not all passive handling, but there is definitely some active components too. So there have been some changes over time as well. Yeah.
Yeah, it's good to know about that, because I think there's elements that when we talk about what is NDT, there are probably different pictures in our heads depending on when we were trained and who was around us at the time and who our influential leaders were. And if it was done quite frequently and across across the world, I'm sure there's quite a few different approaches to NDT as well as a general approach.
That's exactly right. That's right. And one of the parts to that which we'll talk about too is that it becomes an argument that makes it quite hard to test as a single entity. So, that's been a part of debate over time as well.
Yeah.
Absolutely. Look, thanks, Anna. That's such a good summary about what it is and how often it's used, which is obviously forms the foundation for where we move to next, which is obviously over the last 2 decades, there's been some systematic reviews released that have been conducted regarding NDT in clinical practice, namely the fact that more effective alternatives exist where we really harness the self-generated movements and where the child is active and activity-based rehab. So there's a real strong recommendation against passive therapist-controlled handling techniques has been made before, over the last 2 decades in these systematic reviews. Despite all of this, why do you think that NDT continues to be used in clinical practice?
Yeah, thanks, Marissa. I think that's very true. This is not a new debate. Yeah. And NDT, I think it's been used for a very long time, and it's really been the mainstay of therapy internationally for a very long time. Yeah. So a part of what we know in therapies too is it's not that easy to stop something that you've been using for a very long time. That's a part of what we know is hard. And in fact, it's even harder than implementing new evidence-based therapies. So I think we should keep that in mind when people are thinking about this. Yeah. But I also think there's an element, and I'd referred to it before, but people were not completely confident that the evidence was strong enough for them to really stop something, and something they've been using for a very long time.
Sure.
There's been, in the literature and debates around, some of the reasons that people posed was that, as we've just discussed, NDT is a really varied practice.
Yeah.
So making it harder to combine and test that as an entity by itself. So that made people feel a little bit less confident in the results. There's also proposed that some of the studies that we used were underdosed. So by that we know that often you need a certain dosage to know if something can be tested. So I think that added to people's lack of confidence. So I think that's probably some of the reasons that, I mean, this has been going on for a long time and there's been recommendations for a long time, but there must still be a reason that people were still keeping using it. Yeah.
And I think the point you make there is such a strong point as well, because I even remember when I was trained, it was such a big commitment. So there was funding I had to obtain. It was 7 weeks where I relocated to another state to learn. So there's a lot of personal investment in that. And when you're in that environment, when you're learning, because I think, NDT and the training that does go around that, they've done a great job, if you're looking for more skills. And so when you start to see the evidence kind of evolve, it's a harder thing to let go of if you've been quite attached to it or if you've invested into it quite a fair bit as well. I think that's the real tricky part of it. So I think, it's great that, your study or your meta-analysis was broad to be able to identify all of these areas. I guess that leads really nicely into what you actually did in this meta-analysis and what you actually included in this as well. So can you just talk us through some of the methodology, because what you did was very robust and very strong. And I think it's really worth highlighting what was included in that. So can you give us a summary of all of that, Anna? I know there's a lot there.
Absolutely. That's right. We of course, wanted to use the best methodology we could because this debate had been going on for such a long time. We used what's called the Cochrane methodology. It's not actually a Cochrane review, but we used all of the same methods that are recommended in Cochrane methodology. And for the papers or the infants that we included, they were infants who had cerebral palsy or high risk of cerebral palsy and under 18 years. We looked at the different interventions, and we looked very broadly any interventions that in the papers were called Bobath, NDT, neurodevelopmental therapy, and we looked for any comparisons and any outcomes, but we only wanted to include the highest levels of evidence in order to not muddy what was seen, and so we only included randomized controlled trials. We also made a decision, I had a big discussion because of this question about dosage. More recently in the literature, there's been evidence which is starting to suggest that we know we need about 30 to 40 hours of activity-based interventions to improve motor function. And we wanted to help answer that question about were the studies too underdosed. So we excluded in the dosage question about underdose studies as well. They're the methods that we went ahead and used.
That's really unique to actually put in there dosage. And I think that's so great you put that in there, because you're right. That's often what you see when you read the papers. You're like, oh, well, it was underdosed. It probably didn't quite meet, the threshold for change. And then as a result, you do tend to might disregard it if that's sort of where you're sort of headed with in terms of your thinking about it as well. So that is so unique. Yeah, and
I think it those parts to the question, without doing that really rigorous methodology, it just erodes away your confidence in what you can take from the studies. So we tried with that methodology to tick off every possible box available so that we could feel really confident in the results.
I love how rigorous you were. So now, after going through that,
thank you. It took a long time.
I was going to say, how long did it take? Just out of curiosity.
I don't even know. I don't count the hours.
Oh gosh, there's a lot. Well, once we look at the numbers, you can probably start to think about how long this might have taken the team.
It's good though, because it gives us that confidence that the studies you have included, you've done so much rigorous work to find specific, the best, so we can be really confident in what it is you're saying, which is where we move on to results. So Anna, can you tell us, obviously you went through that large process of reviewing the articles, and how many studies were included in the review?
So when we looked at several different databases, and we found 660 records that we screened through. But in the end, there were 34 studies that were randomized controlled trials. And in total, it was 1,332 participants with CP that we combined together.
Great.
Wow. And so, I mean, even that's quite incredible. Just on a side note on that there were that many RCTs as well that we could actually look into it, which is really cool that, clinicians and researchers have really been trying to look into this area and have conducted RCTs, which just knows it's not an easy thing to do in this area, is it?
No, they are definitely not. And I think in reaction to this paper, we've had quite a few people surprised that there were really that many randomized controlled trials.
Yep.
And I think in putting it, wider context, like this is really getting more RCTs than in most areas of cerebral palsy. Cerebral palsy is a relatively niche area, so it's really a large body of work when you pull it all together.
Wow, that's incredible.
Fantastic. Now, can you talk us through effect sizes and what they mean when we're interpreting the data from these studies?
Yeah, for sure. So when we're looking at an intervention and if it works, we don't just want to know if it works, we want to know how much it works, how big the effect is going to be. So how much bang you're going to get for your buck. But when we, sometimes it's harder with numbers to know what that means. So we've used something called Cohen's d, and that puts some words on what the effect sizes are. So an effect size of 0.2 is considered a small effect. An effect size of 0.5 is what we call a moderate effect. And then we move on to large effect, which is 0.8, and a very large effect is 1.3. And again, in cerebral palsy, this is, a permanent movement disorder. So getting large and very large effect sizes is pretty rare, actually. So that kind of puts that in context too.
Yeah, the Cohen's d is such a nice number to be able to summarise data, isn't it? Because I can imagine there was a lot of data that you had to go through, and for people to be able to understand the depth of the effect is probably really important. So I guess, like, leading on from that, then really curious to know all the different kinds of outcomes that you were able to investigate in all of these studies.
Yeah, that's right. So obviously we looked for any possible outcome, and probably not surprising, the most common outcome reported was improvements in motor function. That was actually in 28 of the studies. The next most common outcome was general development, and that was in 4 studies. So motor function was the most common outcome by far, but we had many other outcomes that reported. So, for example, reflex status, cognition, social development. There are also outcomes for mobility, walking capacity, also quality of upper limb movements, muscle length, muscle strength, muscle tone and spasticity. And the last few were mechanical efficiency, sitting function and self-care. So they were pretty broad, the outcomes that were reported.
Which is also really interesting. I'm glad that there was reflex status in there, because I feel like there's a big part of NDT approach that is on reflex. So, how do they measure reflex? Just out of curiosity, how do studies do that? Yeah,
absolutely. So some reported on reflex status. There were a couple of studies that used a reflex profile. It's not, we looked into that, and it's not necessarily very commonly used, but it was as close as they got to a standardized outcome, I guess, for reflex status.
Yeah, sure. But I guess the good thing to know about that, knowing that you had, the 35 studies that were done where, 28, did you say, were on motor function?
28, that's
28,
right.
Yeah. That's pretty good, because in the sense that, in terms of being a very motor-based intervention and the outcome was primarily, based on motor, I think it's a really good thing, isn't it? So we can actually really look at all that data.
Absolutely. And I mean, it makes sense. If it wasn't primarily looking at motor outcomes, that would be a strange finding. So I think it very much makes sense, and it's good because, in the end, we are, wanting to help children learn how to move. So it makes sense that was a common outcome.
Yeah, that's really cool. Okay, so now for the results. So we've got a few different comparisons that you did make, NDT versus a few different variables. So let's start to go through them systematically. Then we can really talk about what that means and how that was in context with all the results. So I guess the first comparison that was made was NDT versus control. So can you just describe what control actually means and what the results were around that?
Yeah, for sure. So you're right. We coded all of the papers papers into different comparators to help make sense of them. So for control, they were papers that either had NDT versus no therapy. Many of them were older papers because that's not really ethical to do that anymore. Or papers that had primarily just a passive, like purely passive interventions. So that's what we pulled together as control. And between NDT versus control, we found that there was no difference between those two. The effect size was 0.13, so that's small, but I think probably more importantly than that, we also looked at this idea of a 95% confidence interval. So we're 95% confidence that it falls between a range. And that range fell over what we call the line of no effect. So that's why we can say that there was no difference between NDT and control.
Okay, fabulous. All right, so that's a really good thing for us to note then if you're going to look at that. And you're right, isn't it? It's not like you can do any studies these days. It's almost that you forget that that's probably what was done, is to have no intervention at all. It's not really a done thing in our studies. That's probably really good to acknowledge. So the next comparison that you made, so it was NDT versus activity-based approaches. So just talk us through what activity-based approaches, you mean by that.
Yeah, absolutely. And I know we'll go into a bit of detail of this, but this is where primarily the child is actively involved, and they are therapies where the children are actively generating movements and setting goals and interventions like that. So we actually found 8 studies that we had enough that we could pull together, so pull the results. So it wasn't just one study, but pulling it into this single result. And the effect size was 0.76. That's considered moderate, and it favoured the activity-based approaches. And again, importantly in this one, that 95% confidence interval did not cross the line of no effect. So that means that we can very confidently say that there was activity-based approaches were more effective than NDT for improving motor function.
That is such a good outcome to,
I love how clearly you explain it. It just, it makes so much sense.
It really, really does. And I love that it was just, that you were able to pull that many together as well and be able to define them as activity-based approaches. And I guess that wasn't just for lower limb, wasn't it? There was other components of there. There was also upper limb involvement as well.
That's
outcomes.
Right. So that's right. We did an overarching analysis on those activity-based approaches, and then we wanted to see if there were other elements that changed. So when we pulled out just upper limb activity-based approaches, so just looking at how the hand was working, we actually found an effect size of 0.83, so a large effect size. Wow. And again, that 95% confidence interval didn't cross the line of no effect. So not only is it effective, but effective to a large effect. That's right.
That's a very large effect, 0.83. That's definitely very large. Very confident, I can see. And then
that's right.
The next one was really intriguing to me, the NDT versus body structure and function approaches. Talk me through that. Like I'm so curious about this.
This is a bit of an interesting one because, it's not always we looked at NDT versus body structure and functions-based approaches, and the most common reported outcome was on motor function. So it wasn't even most commonly reported on body function and structures-based outcomes like strength and tone. So, but even, we know more widely that often when an intervention is targeted at a certain things, so body structure and function like strength, you'd expect it to improve strength, but it also improved motor function. So, and the effect size was 0.77, favouring body and function structures approaches. So that was an interesting result from our end. It makes sense to us that by the mechanism of actions that the activity-based approaches would improve motor outcomes, but also these other body structure and functions-based approaches still did improve motor function more than NDT with a moderate effect size.
Wow. And can I just ask you on that one? So some of the body structure and function interventions, I'm gathering, was like muscle strengthening protocols.
That's right. That's exactly right. So anything that just was aimed at changing a body function structure, so muscle, tone development, things like that. Yeah,
which I think is really interesting as well. I remember at the last Oz Academy conference, I was part of this symposium. So there's a lot of really smart people in this one area, and it was all about muscle strengthening. And the physical therapist I was speaking to, Dr. Noelle Moreau, she was talking a whole lot about, sometimes I feel like we forgotten about how good muscle strengthening is in children with cerebral palsy. If you can increase their muscle power and their muscle speed, that's really strongly related to their walking speed for particular GMFCS levels. And I remember her saying that, and I was like, we have to remember there are those sort of flow effects as well, because for some of our kids with cerebral palsy, body structure and function, like strengthening is such an integral part, particularly if you're quite deconditioned. So I thought that was a really, really interesting one that you had there.
Yeah, absolutely. We also looked, though, of course, understanding if it had differences on the outcomes. There was muscle tone, and so body structure and functions-based approaches did favour improving muscle tone, but it was versus a therapy called neurofacilitation of developmental reaction approach. So that was only for two different papers that we had for that one. We also found that there was no effect on this idea of primitive reflex status. That's what I was talking to you about before. But those ones, those two, I think we definitely need to treat them with a little bit of caution, because it was only the two papers, and when we looked more closely in detail at those papers, they both had high risk of, judged what we call high risk of bias. So we have to be a little bit careful in pulling out those findings.
Yeah, no, that's really interesting. And I know that there's a lot of sort of NDT principles or that talk about this integration of reflexes, and it's always been this really interesting concept. So I'm glad that you were able to find that in some of the studies to be able to report on, even though that there's that high risk of bias for those studies, but it's worth acknowledging. Yeah,
that's right.
So Anna, can you talk me through now the cohort, the NDT versus environmental based approaches? Can you tell me a bit about the studies?
Yes, for sure. So we look widely. I mean, we're starting to know that environmental-based approaches can be a way to improve motor function too. We only found 2 studies that fit into this category. So one partially favoured NDT, but that was in comparison to non-specific handling. And there was another study that favoured the idea of parent coaching over NDT to improve motor outcomes. But those 2 studies were very different from each other, the 2 environmental-based approaches, so we couldn't it didn't make sense to pull those together into a meta-analysis, so we didn't have a combined effect size for those.
That makes sense.
Now the next one, I really love how you compared NDT high versus low dose, because as we talked about, dosage is such a paramount question right now in the research world and everywhere, in terms of how many hours do we need, because we don't want to be doing too much and we don't want to be doing not enough. So can you tell me a little bit about what you found when you compared high versus low dose NDT?
Yeah, absolutely. So in the end, we found that there were 3 studies that we could pull together, and remembering that a part was that we excluded studies that had less than 30 hours included. So when we pulled those 3 studies together, the average of the low dose group was at 35 hours, so over that dosage threshold, and the average of the high dose group was 90 hours.
Wow.
And what we found between those 2 groups, that there was no difference between the groups. The effect size was 0.32. But again, coming back to that 95% confidence interval, it crossed over the line of no effect. So that's why we can confidently say that there was no difference between the high and low dose NDT.
Wow, it's a very powerful conclusion. But like you said, you've got the evidence and the way you've explained it to back up what you're saying.
And when you consider what 90 hours means, I know we're talking about when we bring it all together, I can't help myself now, but I think, when you think about what 90 hours means in terms of being more effective or not, I think that is so powerful. That's so integral, because that's just time, that's resources, and that's possibly time not doing something that's possibly more effective as well. So it's significant.
And things like playing with your friends and going with your family and things that just, aren't therapy. I mean, those are really important hours in kids' lives.
Yeah, absolutely. So powerful. Yep.
Now, I think it's the last little cohort is NDT in infants. Can you tell us a little bit about the studies that were included and what you found in this area?
Yeah, that's right. So we're always interested to understand what's effective in infants when that brain is the most neuroplastic. And we did find that 11 of the studies had babies or children under 2 years of age. We found that 2 of the studies favoured NDT, 1 of the studies partially favoured NDT, and 11 did not favour NDT. And again, that's a lot of studies looking at babies, but the range of studies again were quite mixed. So we looked to see if we could combine any of them to make a meta-analysis, but it didn't make sense to do that. So we couldn't get a single effect size out for those.
Gosh, what a comprehensive set of comparisons. And I think, you can sort of see where you're headed with this in terms of what it means. Like we said earlier, we've always been a little bit tentative to say there's not enough evidence. And I remember when we first looked at those big systematic reviews that Anna Novak led with a whole team, looking at the grade as well, when you sort of talked about NDT being below the line, it sparked a lot of conversation. Where do you think it now sits, given the body of work that you've now done and these really comprehensive results? Where are we sitting now with NDT?
Yeah, I think that's really great to put that in that historical context, because there was a lot of argument that the volume of evidence testing NDT was too small and that the quality was too poor to fairly or adequately test NDT. But I think we've looked very broadly, and 35 randomized controlled trials. It's, as I said before, it's it's bigger body of evidence as we have in most topics of CP. So after methodically going through all of that literature, and it's all pointing in the same direction, I think we can be pretty confident to say that there's no difference between NDT and control, and that we've got other effective alternatives in activity-based interventions, and which are superior to NDT for improved motor outcomes. So we've got alternatives that we can use.
So I think that is really powerful, and you've presented it so beautifully in a very similar way, like we sort of said in the, the grey chart, the bubble charts. And I really encourage everyone to have a look at that, because I think it really contextualizes it. It's a bubble chart we're very familiar with now. This is a sort of a question I can just imagine being asked. We've got all these RCTs and this bubble chart, and it's very strong evidence. We know that. What do you think about, how can we sort of have those discussions with people who sort of have more anecdotal sort of evidence, kind of go, well, I see in my practice, these great gains in these sessions, the child can do more after a session. How can we have those discussions now, knowing we've got this weight of evidence behind what we're saying?
Yeah, I think this is really the most important question, because this study is very strong and it's very robust, but it doesn't take away from the day-to-day experience that you've had, or more importantly, that a parent has had with their child as well. So it's really important not to say, well, that's not true, or that hasn't worked. But another way I think that we would look at it is to be able to say that we've done a lot of work, and what we can see is there are actually alternatives which are going to work better for your child. And again, knowing it needs to be specifically for if we're trying to improve motor or improve movements in a child. So, previously I've also used the bubble chart, both with clinicians but with parents too, to be able to show where the numbers sit with that. But it's really important to acknowledge experience that people have had, because it's not helpful to say, well, that experience is not true. So it doesn't take away from people's own experiences that they've had with that.
I guess it just highlights the importance of having proper conversations, isn't it? It's to kind of, and a conversation is never one-sided where one person's berating the other. It really is a conversation and understanding experiences. But like you said, it's to talk about what those alternative and more effective interventions are. And I think that's a really powerful angle. So I thought we'd sort of spend a bit of time now sort of bringing it all together and kind of going, well, how can we contrast those different features, and how can we identify the difference between more effective interventions and the less effective interventions? And I thought, well, let's tease out the principles, I suppose, of what we can see in NDT first up. And because I know there's other interventions that are not named here because they haven't had any studies done on them. So at least NDT has all these studies done on them, so we can talk about it. But there are some very similar principles, when we talk about reflexes and normalization. So can you talk us through a little bit about those real features now that, can help us to identify an intervention that sort of probably fits in the same category as NDT?
Yeah, for sure. And, you know, I've had these conversations with parents quite a lot because it's very natural and normal that parents are going to look everywhere and do everything they can for their child in order to try and improve their child. So I have these conversations in my clinic all the time. And what I say to parents is, you know, you should try what you think is right for your child. You know the best way to make a decision for your child. But these are the features that I would go ahead and some that I think you should look out for in case they're happening, and the features that you should look for in an intervention that we know has evidence base behind it. So the features, I think, you know, I guess what you're referring to is in data in the paper, we pulled out all of the different features of all of the different different studies, and some of those features that came out in these what we call bottom-up approaches are the idea of facilitation, so trying to, you know, move the child, not have the child generating their own movements. The next point is handling. Now, this is one that really is worth teasing out because the idea of handling is we're not just saying absolutely always have your hands completely off the child, but it's the idea of facilitating or generating movements that the therapist is generating or a parent is generating. And the idea too is that it's really giving that sensory feedback and this idea of improving quality of postures. That's the part that you know, becomes that feature that you're talking about. There's also this idea of positioning to try and normalise postures. You know, a really great example is you're trying to learn to sit and the trunk is, you know, a little bit to the side and you're putting your hands on trying to make the trunk look more normal. So these are the bits that we are saying are not helpful. There's also facilitation and handling to try and improve tone or reflexes. So you know, I've seen therapists before, like trying to help a parachute reaction and things like this. I feel like we're probably beyond this, but it's worth pointing out that some of these interventions still had passive stretching, and I still often have conversations with parents about passive stretching. You know, baby massage is good and nice, but also it doesn't have an effect on improving motor outcomes. There's also these ideas of sensory support, which I've talked about, and vestibular input. So it doesn't necessarily need to be called NDT, but these are the kind of the features that I would talk to parents about. You know, if they're seeing this in a therapy or being asked to do this in a therapy, that these are things we know won't go on to improve motor function.
And I think the way you've teased it out is so good. I think what I can feel there's some confusion sometimes is like what is active versus what is the therapist generated. Like I've seen, you know, you don't have to go very far on social media to see these sort of acrobatic tricks where you sort of, you know, flipping a child around so they've got a better right-in reaction and then they have a better head control. And so, yes, the head control when the child's lifting their head appears active, but it's not being generated by the child. It's being initiated by the therapist to sort of elicit that reaction. Is that a way to describe it? Because I feel like that's absolutely a really excellent way to describe it. And I think, you know, when we talk about these ideas of what is going to be effective in improving motor control, is exactly right. What is child generated? And so that's the difference between setting up a room where it's fun and the child wants to play and they want to try and lift their head up and look up or look at their parent or something like that. And so it's not a therapist hands-on trying to get that reaction for head control. It's getting the whole environment around the child, and so that they are attempting to lift their head, and they're doing it in. I think that a really important feature is we talk about you know, real life environments in which to learn a real life goal. So that is really you know, learning to sit and learning to sit up, but you're doing that in order to play, in order to be with your family and all of these kind of things. So that's the way at which it's the child is generating the movement.
And I love how you describe how you explain things to families, because I think that's, you know, part of our role as a therapist is obviously in education, and we definitely respect so much that parents have a choice to choose what therapy they'd like their child to participate in. But I guess one of our responsibilities as a therapist is also to advocate for what has strong evidence, and at least give them that information from there that the parent can make the decision. So can you talk us a little bit, you obviously talked about the features of that kind of bottom-up approach. Can you talk to us now about these effective interventions that we know from the top-down approach and what features of these interventions are?
Yeah, that's right. So there are several features which we pulled out, and probably not surprisingly, they all line up together with this idea of activity-dependent neuroplasticity. So it's active and it's making the brain work, basically. So I did refer to them a few there, but some of them are really that learning through active self-generated movements. So the child needs to be the one initiating the movement. But there's these other features too. It needs to be progressive. So we talk a lot about a just right challenge, for example. So it needs to be quite challenging for the child, not too easy but not too hard. But another really important factor was it needs to be repetitive. So children need to practice over and over and over again. And it's a real key as a therapist's role and a parent's role to make it fun so the child wants to repeat something over and over again. So that becomes your role rather than kind of getting your hands on to help the child repeat over and over again. The next part is really variation and task-specific practice. So that means what you are trying to learn is what you do. If you're learning to sit, you practice sitting. If you're learning to stand, you practice standing, but you do it in a varied way. So not at the same set of parallel bars every day. What that means is getting it in also to real life practice. So, is a child being able to stand at school, at home, in the lounge room, in the bedroom, in the bathroom, all these different environments to repeat that practice over and over again. A really essential element, we've kind of touched on it, but really the most essential element is having real life meaningful goals and as soon as possible having the child direct those. So it's, and this is not just saying that therapists don't have expertise in what's next for a goal, but if it's not meaningful to a child, they won't be motivated and they won't want to do that repetitive practice. But as soon as it's meaningful for them, I can tell you kids will drive that practice themselves. Definitely.
And that's absolutely key. So, and I guess, to sort of conclude that, what you sort of said in your paper, which is a very powerful statement, and I've seen this posted a fair bit on Twitter as well in terms of one statement, and it was, this current research does conclude that the de-implementation of NDT in cerebral palsy is required. A very powerful statement. Is there, any advice that you would give for clinicians who might be practicing this area now and is, looking at this research and what this means for them?
Yeah, I think there's some really important points here. So I've said this before. We know that it's harder to stop things that you've been using. So if you're finding it hard to change this, that's okay because it is hard. And it's harder even than putting new interventions into your practice. So, but if we look at the de-implementation science and tells us what works to try and stop using these practices, there's a few things that we know are needed. You referred before, Dana, really smartly to this NDT training, and it's very comprehensive and it gives a great basis in developmental therapies. So really what we need is very good training and readily accessible training into these effective activity-based interventions. Some of the named interventions are Habit-Teal, for example, constraint-induced movement therapies. People need to be given access to being able to train in these therapies so they can use them in their practices. But there's other aspects too. So looking at policy changes, so organisations making policies that they'll be stopping the use of NDT. It's not always just easy for a therapist by themselves to go forth and conquer. Of course, you can do that, but there are a lot of other things around people stopping them as well. We've also discussed, and this is that's a big one, I think, but something that needs raising is the idea of funding different interventions. So, for medications, they are only funding evidence-based medications. So we need to do work on being able to only fund these active, effective interventions. So, I think generally as clinicians, we all really just want what's best for the children we see. Everybody wants the same for that. And as clinicians, we are taught, and we constantly reevaluate our practice in light of new evidence that will be continuing for always. So I think knowing that there are these alternatives and how to use them, you can go ahead and do that, but also know that if you're finding it tricky, there are other things that need done as well.
That's really good advice, hey. And I think, I don't know, Marissa, what do you think?
I just think, like you said, and it's about putting yourself even with the right people, like finding mentors that align with those effective interventions, because whether you're a new grad or you're someone that's practiced for 10 years using NDT, I think if you're align yourselves or get mentored or encouraged by people that, really believe and follow evidence-based practice, then when you talk to them and have discussions with them, you won't help but be able to change the way you do things. And even though our hands might not be on quite so much, if we're, with doing these effective interventions and allowing the child to be more active, it's still such a fun and amazing role as a physiotherapist, because you see the child themselves generate the movements. And then when they generalize it to their own context, at school and home, that's why we do our job.
Rewarding.
So I think it's just aligning yourself with the right people to help educate and retrain your practice.
I think that's a really smart approach. I think that's absolutely great advice.
Oh, that's so good. Well, let's summarise this from all summaries, because we know what's happening next. We're getting into the Tell It to Ed segment. As you know, Ed is our producer. He doesn't have a background in child health, but we know he's been listening. He's been pressing buttons and faders and all sorts of things on the side there. And he's, obviously been learning more and more about evidence-based practice. So, Anna, in about a minute or so, can I get you to summarise this body of research for Ed? And in turn, he'll have an opportunity for a question. So take it away, Anna.
That's great. Hi, Ed.
Hi.
So, Ed, we looked at a common type of therapy that are used in cerebral palsy. It's called Neurodevelopmental therapy, or NDT. And we looked to see how well it worked compared to lots of other types of therapy. And we found that the evidence pretty much all pointed in the same direction. And that is that NDT has the same effectiveness as no therapy or passive therapies to improve movements, and that more hours of NDT you do doesn't add any extra benefit. On top of this, we found that other therapies in which a child actively uses their body and brain themselves to learn movements, and these active therapies help to improve how a child could move more than NDT, and the effect was actually quite big. So we're really confident in recommending that you use these active therapies to help a child with cerebral palsy learn how to move, and we're also really confident in recommending that you don't use NDT to improve movements.
Oh, that was such a good summary.
Wow.
You did so good. Anna, that's amazing. You summarised that so well. Well done. Well, Ed, time for a question. Over to you.
Oh, I only get one question, is it?
Well, let's go with that for now. He's curious. I can see he's curious, Anna.
Well, my track record has allowed me to have a second question these days, but I think I've been really intrigued to obviously sit through the last 49, 50-odd episodes of the podcast and realise the kind of language that's used by researchers and clinicians and tends to be very, very tentative, very careful, very considered, very measured. And so I kind of, on one hand, kind of understand why there is a bit of a tentative approach to taking on board new research and new ideas. And then I guess I don't quite understand the psychology aspect of holding on so strongly to the past that we miss the new and improved version of what it is that a clinician would get to do from day to day. So my question is more about the psychology, and I'm struggling to put it into words because because some of the words are too strong, whether it's being arrogant in your craft or whether you're being far too cautious, or if it's some sort of combination in between. But are we looking at families that perhaps need some better education in the options that are available, or do clinicians need like better training, or do we need like a body of some sort to step in, like a government regulation to say, look, this is a much better way of going about it? And I know you've kind of touched on all of that, but is there something that kind of wraps that into a bow, essentially?
Ooh,
I think it's a really, really smart point, Ed, and I think it's probably why this has been a debate for a very, very long time. Parents are smart and they know how to make good decisions for their family, for their children, but also there's a lot of information available in a lot of different forums, and our job as both clinicians and researchers is to try and put the best information forward for families.
Sure.
And different families need different things, but I think that there can be a role for bigger government agencies to help make decisions about which therapies should and shouldn't be used. But it's also why we do this work, to try and back that up with more confidence. So, I think you've pinpointed a lot of the reasons why this has been a strong debate for a very long time. And, there may still be debate around this, but we've tried very hard to work through this really methodically to be able to make the confident statements that we've made.
Yeah, there's a great conclusive statements, like you said. Like previously leaned to this, I think we're all a bit tentative. The evidence suggests, and it's head in this direction, but the sample size wasn't big enough, and there were all these sort of more tentative statements. Nice one, Ed.
Thank you.
Yeah, that was a good question. Really good question. Well, Anna, I think you've been very informative through all of this. We've just absolutely loved our conversation with you. Like, this body of work, I can't even begin to, comprehend how much work has gone into it. But the team that you had behind you as well just looked absolutely incredible. So huge congratulations, Anna.
Thank you very much. And I'm chatting about this, but it's not just the team who did this work. And I think you've referred to this too. This has been years and years and years of work, and it's all an evolution. And may we continue to evolve in looking at what we do in practice always. This is not the end of it.
That's so wonderful. Yeah,
I love your passion, Anna, and how well you explain things. So thank you so much. It's been a pleasure.
So good. Great. So remember, to all of our listeners, you can have a copy of the run sheet notes as well as a link to the paper on our website, researchworks.net. And remember, there's a CPD form there that you can fill out as well if you want to keep this as a part of a record of your PD requirements. But for now, we're going to have to say goodbye. Thank you so much once again, Anna, for joining us, and can't wait to share this with everyone.
Great. Thanks so much for the opportunity.
Fabulous. Well, thanks to everyone, and we'll talk to you all again next time. Bye.
See you later.